Now for upper ribs, we had to get 1 through 10. For lower ribs, we have to demonstrate ribs 8 through 12. So the rules for lower ribs, which makes that possible, laying down moves the diaphragm out of the way, expiration moves the diaphragm out of the way, and we need a little bit higher KV. So with the upper ribs, we were in about a 65 to 70 range. Your average KV range for lower ribs, because we're in kind of abdominal tissue, is 70 to 80, just like we're shooting an abdomen. Now what I see happen here sometimes is patients have a really thick abdomen, so people go, ooh, we're going to need a lot more, and they go into the 90s, you know, or 95. At that point, you're creating so much scatter. They take the picture at 95 kV and they go, oh, I still am not penetrating. Oh no, you're well beyond penetrating. You're creating so much scatter, you've completely obscured the anatomy. 70 to 80 is an appropriate range for lower ribs. If you need a little more, you'll go up in mass. But keep your KV down. The higher KV, the more scatter you're going to be producing. So keep that in mind a little bit when you're doing these. So recumbent, expiration, and mid KV range, 70 to 80. Those are the rules for lower rib series. Now, the fourth rule we had with upright was 72 inches. Most tables we won't be able to get 72 inches. So what do? High as you can. Yep. In room 1 and room 2 or any kind of floor room where you can't lower the table, go as high as you can. It's going to be about 46 inches. In room 3, take off the servo. Put the table down, raise the tube up. You'll get pretty close in room 3. You can get some distance in there. But we still want to maintain kind of that 72 inches. So even if it's not possible, use as much as you can. Okay? Use as much distance as you possibly can. So that's kind of the fourth rule for lower ribs, is absolute maximum distance. But it's the same 3 pictures. The same thing that you just did here, you will do laying on the table. We're going to be centered slightly lower. Okay? If we have to see ribs 8 through 12, you center at about that kind of 9-10 region. We know how to find that now. So center at about the level of 9-10 to the site of interest. You do the supine, you do an RPO, and you do an LPO, all centered to the site of interest. Collimate in. If you only need to see ribs 8 through 12, am I going to have light field here and light field halfway down my crest? Probably not. Probably don't really need it that far. If we see crest on your rib pictures, you're not collimating appropriately. So kind of, you know, collimate up. Now we know where lower rib margin is, and we know where xiphoid is. So we know kind of centering, we know collimation. But those will all be done on their backs. So that's your 7 pictures. PA chest, 3 pictures standing, 3 pictures laying. Okay, it seems like it's a lot more effort and a lot more work, but there are a lot of things built in that make it easy. Your tube stays at 72 inches. When they're on the table, they're always on their back. You know, it's a lot easier to roll a patient on their back than trying to roll them around on their belly on the table. For your upright pictures, if they're BBs on the front, you'll do all the pictures facing the board. If the BB's closer to the back, you'll do all the pictures with the back on the board. So there are a lot of things that are built in that make it very consistent throughout. So does anyone have any questions so far about the basic protocol? Anything at all? Pretty straightforward once you kind of hear it get explained. So PA chest, 3 uppers, 3 lowers. Every time, okay, if they can stand. Now there are a few other considerations. I'd kind of mention, like if they're real large, just do a crossways, especially if it's bilateral. If it's unilateral, you can probably, I mean, that's a pretty big film, you can probably get them. These were done at 40, you can tell how much magnification there is. So that's why we're going to be doing them all at 72. But if a patient's really big, even your obliques, you should be able to get a single side on a cassette. But bilaterals, you know, you might have to get a little bit creative. Some other scenarios, what if a patient is unable to stand but has upper rib pain? What do you do? What do you start with? What's your first picture? AP chest, upright as possible. If you can sit them up in the bed and get that AP chest with the BB, That's your starting point. If they cannot stand, if they cannot sit on a stool, they absolutely can't, you can only get them semi-upright, you will do your full series on the table. If it truly is upper rib pain, that will mean 3 pictures after your chest. 3 upper rib pictures. Just because they're laying down doesn't mean you all of a sudden roll over into lower ribs. If they're having true upper rib pain, but you happen to have to lay them down, you can just do the upper rib protocol. So you'll still follow all the rules for upper ribs. You'll do inspiration, you'll do low KV level. Just because they're laying down doesn't mean that you have to change the whole thing. You're still shooting upper ribs. So remember, don't over penetrate. No, you just shoot your 3 pictures laying on the table, and that's it. I've had people ask, well, now that we're doing it at 72 inches, we have to use so much more technique because of the distance, which is true. And they say, well, that's so much for the tube. Like my tube's overheating, or I can't, it's so much technique. There should be some kind of adjustment in there for what KV are you at and what mass are you at. And I think what happens a lot of times is people tend to overshoot ribs because they think like, oh, ribs always look crappy, I'm going to just use all this technique. Be a little bit careful with that. Keep that KV lower and just adjust your mass, and that might help kind of take that factor off of it a little bit. I mean, 72 inches is quite a bit of distance, but it will also help when you're collimating. You're using a lot less of that beam, and so try to get creative a little bit. Ribs, you shouldn't really be having to shoot all that hot. And really the big part that you're trying to penetrate the abdomen, that's when they're laying down anyway. You're maybe at 46, 50, maybe 60 inches, and a lot of that tissue now is spread out. So that should help a little bit with that concern too. Most of the ones I've looked at have been looking pretty good, so I don't foresee that being a huge issue. I mean, we obviously get patients sometimes that you just can't get through, but that was one question that had come up a little bit. Remember, 45 degrees is an average for your obliques, so that's also another consideration. Don't under rotate, kind of evaluate the patient anatomy a bit. So just reviewing kind of the differences. Variation in positioning, upright versus recumbent, upright for uppers, recumbent for lowers. Breathing instructions, inspiration for your uppers, expiration for your lowers. Techniques, lower technique 65 to 70 on your uppers, 70 to 80 when they're laying down. Artifacts, we talked a little bit about. Breast tissue is really probably the biggest one. Bra, elastics on bras, so even if somebody says, oh no, I have a sports bra on, still take those off. I mean, just take everything off. That thick elastic, even tank tops that have like the built-in bra or whatever, take it off. These pictures end up with so much detail that those show up. Another one I've been seeing is little old ladies that wear their pants, and we actually see underwear artifact and pants artifact in the lower ribs. Slide them down. We now know where the lower rib margin is, but be really extra cautious because these pictures are coming out, if you use the right technique, with really good detail because we're at 72 inches. So be extra cautious of any little thing that might cause pinching of the skin or any kind of artifact. Sponges, I know sometimes when we do patients on the table and you roll them up into those obliques, we stick a sponge under there. Make sure it's an appropriate sponge that isn't going to show artifact. Don't wad up a pillow or a blanket. Use an actual positioning sponge.